Good morning, everybody. Thank you for being here today with us to share a bit of dermatology, basically of clinical cases, and to share different ways to approach clinical cases of skin diseases in dogs and cats. It's my first time in Lithuania, so I'm coming from Barcelona with a shiny weather, 24 degrees, and just I was a bit shocked. So I start to pick up my pullovers, my coats, and everything. Say, well, this is different, but I'm very pleased to be here today with you. And I thank you, Vedma, for inviting me and Affinity for organizing this event. I hope that will be useful to you. I have selected cases and topics with most dedication and interest, and I hope you will enjoy that. What we're going to do is, in the first part, I will talk about skin biopsies and cultures, because I work in a teaching hospital at the university, and I see only referral cases, so cases that previously have been seen by veterinarians, and I see that in many cases when the vet sent a case to me is frustrated because they say, I did biopsies, I did cultures, and still the case is not doing well, so I don't know what I did wrong. So sometimes for the specialists of the European College of Veterinary Dermatology, I give these talks about how to improve the useful of the biopsies and the cultures. I'm talking about cases like this one. So this is one of the worst cases I have had. This dog that you see here had a very severe necrotizing dermatitis, was sent to me because the vet that was dealing with the case had done many things, and they were really frustrated. They say, I have done several cultures of this area, different bacteria every time, different sensitivities. I took 2 biopsies of this dog and sent to the lab for pathology, and at the end only necrosis, pyogranulomatous inflammation, so I don't know what to do. And this is what we are going to do, discuss how to use properly the bacterial culture and susceptibility test and how to get useful information from that. And also, how to use skin biopsies to get the most useful clinical information. By the way, this dog did well. I repeat the biopsies, had a severe necrotizing idiopathic pyogranulomatous dermatitis and responded very well to cyclosporin. So in some cases, taking the right biopsy and sending it to the adequate pathology can solve the case. It's not simply, I did cultures, I did biopsies. It's doing this properly. So we will begin with biopsies. Why we use so many biopsies in dermatology? Well, because it's a very useful technique, because the lesions macroscopically all looks very similar, but microscopically there are differences. So taking biopsies and doing an histopathological analysis gives you a lot of information. A lot of information in all cases. I try always to explain to my students that if you do a thyroid test and you check the 3 T4 levels and TSH, because in your differential you have hypothyroidism. This test only tells you if the dog is hypothyroid or not. That's it. If it's not, you don't get more information. With a biopsy, this is different, because in all cases, it provides you with useful information. You can suspect that the dog has, for instance, sebaceous adenitis, and you take a biopsy to diagnose this. But the report says, no, it's not a case of sebaceous adenitis. Simply, it's a perivascular dermatitis that we see in allergic dermatitis. So in all cases, the biopsy will help you, even to rule out things and give you an information that is completely normal skin. It's a not very invasive technique. It's just a few wounds. And also a good thing of biopsies is they can be reviewed anytime by a second pathologist. If you discuss with them and say, well, what you say is not clear to me, can you review the biopsy? The biopsy remains there for months, years. With cytology, this is different. With other techniques, the technique is only valid for a short period of time. But with biopsies, we have this. I can review your cases from 2 years ago. I can talk to your pathologist, send me the biopsy, we will check if the changes are compatible with this disease or with the other disease. So in which patient are we going to do a biopsy? In principle, there are very few contraindications for biopsy. Only maybe patients with hemostatic disorders, because it's not very invasive. We use the biopsy when other less invasive techniques have failed or cannot be used. For instance, we are not going to use a biopsy to detect Demodex mites because we know that simply with skin scraping, we can detect the mites. So we are not going to use this when there is another technique that is less invasive, appropriate, or useful. Also, we know that in some clinical cases, in some clinical presentations, the biopsy is not discriminatory enough. For instance, in pruritic dermatitis, like this dog with atopic dermatitis, the biopsy is not very useful. It only will tell you, we see a perivascular dermatitis, can be any allergic condition, flea allergy, food allergy, atopic dermatitis, drug reaction, many more. So if we make a very simple classification of cases where you have to consider a biopsy, these 5 situations are the typical ones: nodules and tumors, vesicles and pustules, papules and plaques, chronic ulcers, and non-pruritic symmetric alopecia. In these situations, usually the biopsy helps you. Maybe you can begin in some of them doing other things. Of course, we can begin with cytology in some cases. But at the end, the biopsy will be the definitive diagnostic tool in these conditions. So how are we going to do the biopsy? Well, basically, there are 3 points to be considered that are extremely important. Selecting the biopsy sites, sedating the patient, we will see the different approach, and then doing the biopsy, performing the biopsy. The most important of the 3 is selecting the sites of biopsy. Most mistakes, the first one that you have seen at the beginning of the talk, are consequence of a bad selection of the sites. And this is something that needs a lot of consideration of thinking before proceeding to select the sites. There are very strict rules about how to do this, and depends on the lesions that the patient has. Still, at least in other European countries, many vets think, I need to take the sample from the healthy and sick skin, or from the area in the middle, or from new areas. These are not good criteria. If you use that, the biopsy will be useless in most of the cases. There are very strict rules where to pick up the samples. And then we have to look at the patient entirely and select carefully 3, 4, 5 sites for the biopsy. And that depends on the lesions that the patient has. We know, for instance, that in ulcers, we are going to avoid taking ulcerated skin. We need epidermis in all cases. The epidermis is where most of the useful information is. So we don't have to pick up an area of ulceration because we are going to waste the time. In symmetric non-pruritic alopecia, for instance, we want the most advanced area of alopecia. And still, many vets select the area of transition between non-alopecic and alopecic skin. That is very difficult to evaluate for the pathologist. In papules, pustules, and vesicles, we need to collect the entire lesion, the primary lesion. In plaques and nodules, we have to avoid necrotic areas. And in subcutaneous lesions, we need to consider that with the punch biopsy, many occasions you don't get the subcutaneous tissue, so probably you need to do the biopsy with a scalpel. We will see examples of this right now. So once you have marked the areas that you are going to biopsy, we use usually a pen, permanent pen, to mark 3, 4, 5 areas. Then you need to sedate and or anesthetize the patient. In human medicine, if you need to take biopsies of a patient, usually only local anesthesia is used. So they say, I'm going to use some anesthesia. It will hurt a little bit. It's a little bit a feeling of burning, but with that, it's enough. Even this burning that the lidocaine causes can be reduced if you mix lidocaine with bicarbonate, because basically because the lidocaine burns because the pH is very low, it's very acidic. So if you mix 1 part of bicarbonate with 4 parts of lidocaine, it's not so painful. We cannot usually do this because our patients, if you start to collect the biopsy, inject the lidocaine, they get too stressful. In some cases, they get defensive. So usually, except for very calm or sick patients, we need to combine sedation with local anesthesia. This is the normal way of doing biopsies. We combine an alpha-2 agonist like dexmedetomidine with some opioid, butorphanol, and then local anesthesia. This is the way that in most of the cases is used to take the skin biopsies. And in some few cases, you will need to use general anesthesia. When, for instance, when you are taking a biopsy of mucosal membranes that can bleed a lot and you need more time and you need to do better hemostasis or electrocoagulation, or if you are going to take a nail biopsy, we use general anesthesia because to get a better pain control. So in some cardiac patients that you know that dexmedetomidine is contraindicated. So in some situations, we'll go for general anesthesia. But in 90% of the cases, local and sedation. So, and going to take the biopsy, should we use a punch or a scalpel? I would say 95% of the cases, just a punch. A punch is much better. It's better to close. It's better to select the areas. It's very useful. Usually, a 6 or 8 millimeter punch is adequate for most cases. There are punch biopsies from 2 to 12. So 2, 4, 6, 8, 10, and 12. I generally use 6 and 8 for most of the cases. I use the 4 millimeter punch for cuts in the face or very special areas when you don't want to make a big wound. And I use the 10 and 12 for removing nodules because almost the entire small nodule can be put in the punch. In some cases, however, we need to do the scalpel and take the biopsy with the scalpel. And for instance, or the most important indication is deep lesions. When you suspect that the problem is located in the adipose tissue, in the subcutaneous tissue, you don't have to use the punch because the punch don't reach the subcutaneous and you can miss the problem. For instance, a paniculitis, a subcutaneous tissue, histiocytic sarcoma, many lesions that are located below the dermis cannot be, let's say, reached with the punch. Okay? Also, when you want to collect a large vesicle or pustule that with the punch can be broken, or when you want to take a nodule that is more than 10 millimeters in diameter, you need to use the scalpel. I also use the scalpel with the pinna because the skin of the pinna lacks of subcutaneous tissue. And then you, with the punch, you easily damage the cartilage, or in some cases, you can go through the pinna. So with the scalpel, you control better the depth of your biopsy. So in these 4 situations, I tend to use the scalpel. In all the other situations, usually I go with the punch. Remember that it's very important that the area of the biopsy doesn't need to be scrubbed clean with chlorhexidine. So we take the biopsy like it is, with crust, pus, whatever. So we need to collect everything and send everything to the lab. If there are many hairs, you can cut with the scissors a little bit the hairs to facilitate the suture, but we are not going to clean this area before taking the biopsy. We want to have everything as it is. It's one exception for the surgery rules, because usually we learn that all the surgical area need to be scrubbed and clean and perfect. Not with the skin biopsies. We go directly with the punch. Remember that you need to inject the lidocaine. There is a maximum of lidocaine that you can use, that is 4 milligrams per kilo. So I teach to my students that if this is a big dog, you will never reach this limit, because if you take 3-4 biopsies, even if you inject a lot of lidocaine, it's difficult to reach this in a dog of 40 kilograms. But if you are taking biopsies of a cat, small cat, or a small dog, it's better that you calculate the amount of lidocaine that you can use and say, okay, this is what I'm going to use in the 3 sites. That's it, because I'm close to the limit. Remember that lidocaine should be injected subcutaneously, not in the dermis, because if you introduce very horizontal the lidocaine, you can create artifacts. And then you have to wait about 5 minutes. If you don't use lidocaine with bicarbonate, it hurts a bit. It creates a burning feeling that lasts for 1 minute, more or less. And you have seen that some dogs or cats, they feel immediately the lidocaine. Then disappears because the lidocaine has a painkiller effect. Then you go with the punch. The punch needs to be applied perpendicular to the skin and be rotated all the time in the same direction. You will see that. Then you cut from the bases the biopsy and send it to the lab informally. For instance, we're going to take 3 biopsies of these alopecia areas here. We have marked them. We cut a little bit the hairs. You see, we are not in a sterile condition. Just we are removing a few hairs. We inject the lidocaine. And then you apply the biopsy punch perpendicular to the skin and make some tension with the other hand. And then you rotate the punch always in the same direction. Always. The punch needs to be rotated to cut the skin, like this. And you see that the biopsy punch goes through the epidermis, the stratum corneum and the epidermis, the dermis, and barely reach the subcutaneous tissue. But if our lesion is located here, we are going to miss it because the punch has a limit of depth. So in some cases, if I suspect that the lesion can be located here, what you can do also is to combine a scalpel and punch. You can cut with a scalpel, open the wound, and then go with the punch. That's another option that you have. So you see at the end, when you have cut this piece, you can pull the biopsy carefully from one side. Do not squeeze the biopsy, because if you put the mosquito or the forceps on the biopsy, then the pathologist will see the artifacts and say, what is this squeezed mass of tissue? And then you cut below, you see here. Here you see the biopsy, and you can identify the different biopsies that you are taking. You take 4 or 5. Number 2 is from the neck with, let's say, papules, or number 2 belongs to one leg with erythema and scaling. We usually put on a piece of cardboard. This remains attached because of the blood, and then directly to formalin. We will talk later about bacterial cultures and detection of infectious agents. Remember that when you put the biopsy in formalin, it's over the possibility of doing a culture. So the formalin kills everything. We can do PCR and immunohistochemistry from formalin. DNA is resistant. We can detect microorganisms using a PCR. We will talk about that. But we cannot make a culture from this once has been introduced in formalin. In cases where we want to do a biopsy for histopathology and bacterial culture, before that, we need under sterile conditions to split the biopsy, and half of the biopsy will be sent to pathology, half of the biopsy will be sent to bacteriology, okay? And then you need to close the wounds using a cross stitch or simple stitches, whatever you want. The biopsy with scalpel is almost the same, but instead of a round biopsy, usually is an ellipse. An ellipse like this one that needs to be 3 times wide, long than wide. So this has to be 3 times, usually 3 centimeters, and this is 1 centimeter. So you can include the lesion completely. Because this wound is bigger, we usually need to consider the tension lines. So if we go like this on the trunk, like this on the legs. And then you need to close that with more stitches, with more suture stitches, usually 4. In some cases, you need to do a subcutaneous approximation suture. This is useful, for instance, a lesion like that. If you want to biopsy this pustule, this is a case of pemphigus foliaceus, we cannot go with a punch and try to collect this here because the pustule will be broken. We will miss also the satellite pustules that we have here, and we want to include. So it's better in this case, directly go with a scalpel and make a good biopsy. Another issue is that when you send a scalpel biopsy to the pathologist, they know that they have to cut the biopsy like this. It's a consensus. Everybody knows that when you send one of these ellipses, it must be cut like this. So we know that we are going to see this pustule here, all this thing. If you send a punch biopsy, they don't know how to orientate that. They simply cut in the middle. So if you with a punch try to get an area of transition, maybe you will miss the lesion because the pathologists don't know where was the sick area and the normal area. We'll simply cut in half. Okay, this is the theory. Now we're going to see a few practical cases of biopsies, in some cases that were not too well done, in some others that were really useful to reach a definitive diagnosis. Do you have any questions so far? Any comment? You can do this in any language they will translate to me. No? Everything's clear? Okay, move. Let's begin with this case because it's really interesting. This was a ragdoll cat, 2 years old, female, non-spayed, that went to the vet because of this very severe ulcer on the dorsal nose that has been going on for months. So the vet had done many different things. I'm going to eliminate this part. They tried antibiotics, did cultures. Very bad idea because this is probably not a bacterial infection. They did cytologies. The cat has a mild submandibular lymphadenopathy, and the vet was a little bit desperate about this lesion. Was pretty severe. The cat, apart from that, was happy, was living well, eating, normal life, but with very severe ulceration. That has been even growing. It's a young cat. It's white, but it doesn't seem to be in squamous cell carcinoma. Will be very uncommon. Usually they begin here, so it's a possibility, but not very likely because this cat started to develop this with 1 year of age, so it's uncommon. The vet talked to me, sent me the case, I took the images. I said, we need to biopsy the cat. And I make this differential diagnosis. I think this is probably a feline herpes virus infection that causes this necrotizing dermatitis. It could be an eosinophilic granuloma complex. They have been seen eosinophils in the cytology several times, so they were considering that. Could be anthropodbite hypersensitivity. And I talked to her. Okay, we'll biopsy this and we clarify that. I think it's a herpes virus, very severe because in some cases it's not so necrotizing, but we need to do that. She told me, I would take the biopsies, don't worry. The cat was sent to the clinic and she took the biopsies. Probably she selected an area like this. As you can see, this is wrong. And she did the biopsy, and the result of the biopsy, here, this is the piece of biopsy that I got later. You see that it's all ulcer, all inflammation here. We see a very tiny piece of epidermis here, maybe here. And when you look, there are many eosinophils and necrotic cells. The pathologist made this report. Crusted ulcer, diffuse ulcerative dermatitis with predominance of neutrophils, eosinophils, and mast cells in inflammatory infiltrate, necrotic ulcerated epidermis. Compatible with feline herpes virus infection, eosinophilic granuloma complex, insect bite hypersensitivity, the same that we put microscopically. So the vet was upset and frustrated and said, why we cannot make a diagnosis? When in fact, the mistake was done by the clinician selecting an inadequate biopsy site. And as we can see here, because I ordered the biopsy, I reviewed that, I say, this is useless. She asked to do special techniques and say, okay, we don't see clear lesions, but maybe we can do immunohistochemistry, PCR, to detect herpes virus. Not so complicated. So they did the immunohistochemistry and was negative. They did the PCR for herpes virus and was negative. They sent me the results to me, the biopsy. I say, I still consider that this is herpes virus, but if you do not include epidermis, you will never detect the virus. The failure selecting the sample cannot be repaired doing fancy techniques later. It's done. And the cat remained with the lesion and probably healed later on. We lost it. So the assessment is that the site selection was incorrect. And this cannot be fixed later. It's a very important step. Look at this second case. An European, 1-year-old, short-haired cat with a severe nasal ulcerative lesion. The vet diagnosed this as eosinophilic granuloma and was treated with antibiotics and prednisolone, and the cat was not doing well. Not at all. Really bad. Very severe necrotizing problem. Very similar to the previous one. Maybe more severe, but again, a young cat, nasal necrotizing dermatitis, eosinophils in the cytology. So this was directly referred to our hospital by a vet. And we, of course, had the same differential diagnosis, and we wanted to take biopsies. And we selected this area for biopsy. You see, it's close to the ulcer, but it contains epidermis. We don't go here or here or here because it will be the same. We'll have only inflammatory and necrotic tissue. And here you see the biopsy. You see, this is epidermis. These are hair follicles. We are close to one ulcer, but we have plenty of epidermis here. We're going to look here what's going on, because we know that herpes virus replicates in the epidermis only. So we are not going to find the virus here in the necrotic area. We're going to find the virus here if it is. Here you see, this is the epidermis. This is the center of the necrosis. We see a lot of inflammation, eosinophils. In herpes virus, we see a lot of eosinophilic reaction. And then when you look in the epidermis, you start to see these inclusion bodies here and here and here. So you start to consider that this can be herpes virus. See? And then you can do immunohistochemistry on that, because you can say, well, it looks like inclusion bodies, but I'm not so sure. I can then use an antibody against herpes virus and try to find if these epidermis cells are infected with the virus. And this is clearly positive. So I know that this is an herpes virus infection. We see clearly the inclusion bodies here staying in brown in these epidermis cells. So that we can make a good diagnosis, ulcerative dermatitis. We have a clear histopathology. We have immunohistochemistry. We can begin the treatment with famciclovir, that you know is a usual treatment. And you see the progression of the cat. Of course, we cannot repair the necrotic tissue, but at least we stop the inflammation, and then you can, after that, do some cosmetic surgery if you want to close this. We know that this ulcerative and necrotizing dermatitis is pretty common. In some cases, it's not so severe, like these two that I show you that are very bad cases. This entity was reported in '99 for first time in the US, and then we have seen these cats several times. We know that this is consequence of a herpes virus infection, a respiratory infection. In some cats can cause acute respiratory disease. In small cats, they have not been vaccinated. And it can be lethal, even if it's not protected with the vaccine. In some cats, if they are well vaccinated, there is a complete elimination of the virus. This is not so common. But in most of the vaccinated cats, the virus remains in latency in the trigeminal ganglion. And in some cats, because of conditions that we don't know, can be reactivated and cause maybe stress, postpartum, and cause this necrotizing dermatitis. So we see this occasionally, and probably you too. Okay, let's go to the third case. These two represent one of the problems when we take biopsies, the ulcerative dermatitis. Now we go to a different situation. This Portuguese water dog, 6 years old, has a slowly progressing symmetric alopecia on the trunk. The coat is changing. The guardian of the dog say, this is not anymore my dog, it's losing hair, the hair is dull, it was more curled, now it seems to be more smooth, straight. The dog is doing well, no systemic clinical signs, eating, playing, but simply the coat is changing. Everything on the biochemistry, blood work, normal. Thyroid, completely normal. Free T4, T4, TSH, all values within normal limits. Cushing's disease also rule out. So a biopsy is decided just to understand what's going on the skin of this dog. So you see, it's losing hair. There are different spots of alopecia appear clearly. When you look the areas of alopecia or hypotrichosis, it's not clearly completely bald in most of this, less hairs than normal. You see that many of the hairs present this cuffing around the hairs that we call follicular casts. It's a very typical lesion. So the hairs are not completely naked. They are covered with a mixture of keratin and sebaceous secretion, brown in color. If you pluck these hairs with a mosquito and you put under the microscope, something that we do almost in all cases, then you see what is this. Is a amount of keratin and sebaceous material around the hair. The hair is here, this is medulla and cortex, and this is all material covering the hair. This is what we call follicular cast, and we see this in some conditions, and basically conditions targeting the hair follicle, folliculitis, sebaceous adenitis, leishmaniasis, so in some cases. So the first question is, in a case like this, what is the best place to take the biopsy? Am I going to select the limit between alopecia skin and normal skin? I'm going to pick up an area of recently developing alopecia, a new area, or I prefer an old, very advanced case of alopecia. The answer of these three is the third one. Always when you are investigating alopecia, you will go for old and very clear areas of alopecia. Because we know that in all these alopecia conditions, endocrine disorder, follicular dysplasias, sebaceous adenitis, the changes develop slowly. And at the end of the process is when these changes in the hair follicle are most typical. And then is when we want to take the biopsy to understand what is going on. We don't want to take a biopsy of the early changes because they are not so clear. So we selected the different areas, and this is the result of the biopsy. Here you see the epidermis, the hair follicles, here. And what we see is two things. We don't see sebaceous glands. They should be like here and here and here and here. And in one area where the sebaceous gland should be, here, they have been replaced by inflammatory infiltrate. And this is very typical of this condition that we call idiopathic granulomatous sebaceous adenitis that you probably see pretty commonly. It's an immune-mediated destruction of the sebaceous glands that we see in middle-aged dogs, usually between 4 and 6 cases. Until the report of this condition, most of these dogs were diagnosed with hypothyroidism because the people didn't do biopsies, simply blood work. In many cases, T4 that we know that changes a lot and can be low because many different reasons, including some steroids, stress, medicines. So these dogs were diagnosed with hypothyroidism and treated like hypothyroid dogs. And we know that this has two different presentations. In short-coated dogs, tend to present like big spots of alopecia. In long-coated dogs, there's more a change in the hair coat that is reported. Dogs are happy, they don't feel itch, simply the hair coat is changing. And the diagnosis is based on the histopathology after the clinical presentation. And we have good news. This is a disease that can be treated. They respond very well to treatments, usually with cyclosporine. So it's a very easy to manage condition. And I will show you probably later on more examples. So, yeah. No, I go always for biopsy. Yeah, because this, for instance, this condition, if you are not sure that this is sebaceous adenitis, and the dog, as in many cases happens, do not respond quickly, you will have doubts about what is going on. Also, cyclosporine is an aggressive and expensive treatment, so you need to be sure that you have a sound diagnosis signed by a pathologist that this is sebaceous adenitis. I don't try treatments without a sound diagnosis. It's better to, it's not so expensive and not so complicated, so I think it's much better. Also, because you will need to do different treatments, you need to be sure, because the owners will need to bathe the dog. You will probably need to use topical essential fatty acids, use cyclosporin. So it's, to have good results, you have to do many things, and it's better to be sure that this is a case of sebaceous rhinitis. So another example will be this one. This dog with a pustular eruption. Is a Chinese Shar-Pei, 5 years old, with pustules covering most of the trunk, no pruritus, no other clinical signs, skin scraping negative, cytology of the pustules, no bacteria, just neutrophils, some acantholytic cells, CBC chemistry within normal values, and no improvement after 3 weeks of cephalexin. So these are the pustules this dog has. So all over the body, this pustular eruption. See here, papules that become pustules. And this is the cytology of the pustules. So you see 2 or 3 interesting things here. Most of the cells are neutrophils. These neutrophils are not very degenerated, as we see in pyoderma. So they tend to be, in some cases, pretty intact or easy to identify. And then we see clusters of acantholytic cells. This is not diagnostic of pemphigus foliaceus, but is very suggestive. We know that this can happen in other conditions, in pyoderma, dermatophytosis, in some other, say, immune-mediated disorders, but it looks like we are dealing with a case of pemphigus foliaceus. So we need the confirmation of the biopsy. When you look at the pustules in PF are different from the pustules that we see in pyoderma, because they tend to be more flat, not so rounded. They tend to be irregular in the periphery. They have erythematous halo around, and in some cases they present satellite pustules. So if you are careful in the physical examination, in the dermatological examination, you will see this looks like a pustule extending over different hair follicles of PF, very likely. But we need to biopsy this, and probably we need to take a biopsy with a scalpel of that. You remember that one? This is the same dog, a beautiful pustule of pemphigus foliaceus. So satellite pustules, irregular in the form, flat, not so rounded. And we are going to take a biopsy like this. And here you see the histopath. So you see that there is a large subcorneal pustule here. And when we look inside the pustule, we see the acantholytic cells that we were seeing in the cytology. But in this case, we know clearly that this is a case of PF because the pustule is subcorneal or intergranular. There is big clusters of epithelial cells. We can exclude dermatophytosis doing special stains, so we can make a good diagnosis of PF in this case. And finally, let me talk about one case of nodules in this Persian cat. This Persian cat was referred to me. I think this case is not from Barcelona, it's from the US. I have been living time in the US, and this is one American case. This cat was referred to me because the guardians have detected a nodule on the tail. They think that the nodule have been there for a few months. It seemed to be sometimes painful. They did skin scraping. The referring vet did cytology of the nodule and detected a pyogranulomatous exudate. Biochemistry, blood work, everything was within normal limits. Was treated with different antibiotics empirically. They took samples for bacterial culture and they identified Escherichia coli. that probably was a contaminant. The tail of the cat, imagine, easily contaminated with Escherichia coli and other enterobacteria. They tried anyway another treatment that was unrewarding, and the cat was sent to us for examination. So we clip the area, and you see that it was swelling, probably 2 or 3 subcutaneous or deep nodules, dermal subcutaneous nodules, causing the swelling on the tail. Here you see better. One of them had a fistula. In this case, because we suspect based on the cytology, pyogranulomatous infiltrate, that this could be an infectious process, we want to have samples for bacterial and fungal culture too. So we're going to take a biopsy under sterile conditions. We're going to split the biopsy, remove the epidermis of one side, and send to the bacteriology lab, and the other half to the pathology lab. So you see, we took several biopsies from all the swollen area, avoiding this ulcerated or this draining tract. This was all differential diagnosis. We consider deep fungal or bacterial infection first, something like phaeohyphomycosis, nocardia, mycobacterium, fungal infection, dermatophytosis, so deep, other deep fungal infections. We consider the possibility of neoplasia. Was 5 years old, tail gland hyperplasia. It's too young. So in this case, because we have this in the differential diagnosis, we're going to do both from the same biopsy. So we can use a same skin biopsy or biopsies for bacterial cultures, for fungal cultures, for histopath, and even for molecular techniques, for PCR. So if we are going to do this, we have to plan from the beginning, because the biopsy has to be taken under sterile conditions. So we prepare a sterile area, we work with all sterile material, we split the biopsy in half, and even we usually remove the epidermis from the part that is going to be sent to the bacteriology or mycology lab, because the surface is most contaminated with environmental bacteria, bacteria from the gastrointestinal tract. And this deep part is what is sent to the pathology, to the microbiology lab. This is the other half that is sent to the pathology lab. And here you see what is happening with this cat. Here you see the epidermis. This is the histopathology. And you see there is the epidermis looks absolutely normal. The upper dermis too, yeah. And here you see what's going on in the dermis. A big inflammation, big presence of many inflammatory cells that are located around these structures that you see here. 1, 2, 3, 4, at least 5, 6 maybe. And when you look, what are these big areas or structures here? You see that probably they look like colonies of dermatophytes, of fungal elements surrounded by the inflammatory cells. So, and here you can stain this with the silver stain, with Glaucot stain, and confirm that these are colonies of dermatophytes. At the same time, the fungal culture reveal the growth of Microsporum canis. So this is a case of dermatophytic pseudomycetoma that you know that is almost seen in long-haired cats like Persian, Himalayan, and this group of cats. So it's an abnormal situation for dermatophytes, because we know that dermatophytes are defined as fungi that grow on keratin. So they prefer, they tend to live here because they eat protein first, and they also live here in the hair follicles. It's very unusual that they move deep and grow here. And this only happens in Persian cats and Himalayan cats. very uncommon in dogs or in other cats. But this is a situation that we know. It's called dermatophytic pseudomycetoma. The pathogenesis is not well understood. Some people think that this is because of the furunculosis, that means rupture of the hair follicles and the spreading to the dermis, but nobody has been able to demonstrate that. And the condition is not easy to treat. So we started with the, let's say, standard treatment, itraconazole at 5 milligrams per kg with food. And after almost 3 months, the cat was exactly the same. So we changed to fluconazole. That is not our first one, but we saw a slight improvement and a relapse then. So these cases of dermatophytosis, dermatophytic pseudomycetoma, especially if they are located in distal parts of the body, they are very difficult to treat. So talking to the owners, we say, well, this is on the tail. I think that the best solution will be probably the amputation of the tail to avoid that, because other treatments are not probably not going to work. We surely try terbinafine without any good results. We amputated the tail to our cat. We also clip all the hairs to avoid having spores. And here you see a paper published a few years ago in Veterinary Dermatology about the same condition in 4 Persian cats. They see how big the nodules were. From these 4 Persian cats, only 2 survived. The other 2 developed more and more and more nodules and were euthanized at the end. So our cat, at least, I think, survived without the tail, but could quickly. So in short, we have reviewed how to take, when and how to take skin biopsies, how to select the biopsy sites, depending basically on the lesions of the patient, if they are ulcerative, nodules, pustules, vesicles, with punch or a scalpel. And then we have reviewed a few clinical examples in which the biopsy was helpful, more or less, in solving the problem. So I'm happy to answer any questions or any comments, or share with you whatever of you thoughts. You have questions? Yeah. In general, it's better to stop the treatment if it's possible and let the lesions to develop as much as possible before collecting the biopsy. So it depends a little bit on the treatment. So if you are using an antibiotic, this is usually not necessary to be completely discontinued. If you are using a steroid, it depends a little bit on the dose. If you are above anti-inflammatory dose, I would say more than 0.7 milligrams per kilo of prednisone, you need to reduce a little bit, because the discontinue, I would say, between 5 and 7 days, the treatment before taking the biopsy. Not always this is possible. There are dogs or cats with very severe conditions that you cannot completely discontinue. But if you are at high doses of steroid, is maybe the only situation where you need to stop the treatment. In other cases, you don't need to do that. If you have good lesions, you can biopsy them. Okay. The important thing is that you see clear lesions that you can collect. More questions or comments? No? Everything's clear? No. Do you frequently do skin biopsies? No? Sometimes. Why you don't do more? What are the limitations that you have?
Actually, sometimes because my specialization not as dermatologist, and other well, much more atopic, and as you say,
yeah, not very useful
yes,
with the allergic condition.
Already, I think it's necessary. No,
yeah,
not always necessary.
not always useful or necessary.
Yes.
Yeah. You have in Lithuania a dermatopathologist, a pathologist that is specialized in skin?
No, well, there are some people, but not so much.
Yeah,
And
because
yes,
this makes a big difference. If you send the biopsies to a general pathology lab or even a human pathologist, then let's say the result of the biopsy is not so useful because they tend to make simply description of the, let's say, morphology of what they see. Lymphocytes, plasma cell here, there, all that. And that's, at the end, is very difficult to be used by the clinician because you don't see relevant information. But if you use a pathologist that is a veterinary dermatopathologist, then the information is much more useful.
Yes, to the same topic about pathologists, we have problem that the best our pathologists are in university. They are perfect, but they are not doing marketing. That's our all vets taking samples. Most of vets are taking samples which are working with dermatology, but they sending to only one lab without second pathology. Pathologist reviewing, and that makes a lots of not clear diagnosis, which is real. I would say the biggest problem in Lithuanian dermatologists. They do not do silver stain. They are not asking for silver stain to
detect dermatophytes.
Yes, to do dermatophytes.
Cryptococcus or
yeah. So what I do, I asked for human pathologist to do special stain, and then I do myself because I do pathology.
Okay, that's
so,
another alternative.
Yeah, but I think...
And also for immunohistochemistry, many of the diseases need to combine with immunohistochemistry to detect herpes virus or microorganism. Or
exactly, yes, that's what we missing a lot of diagnoses.
Another possibility is maybe you can send the samples to pathologists in other countries, in Germany.
Would be great to know where to send.
Yeah, it takes time. Yeah.
Yes, and
the big labs like IDEX or LaboClean are operating here.
Yes, we all, not me, most of our vets using LaboClean. But what I'm saying, we have the same problem.
Okay.
Yes, with exactly diagnosis and without possibility to second check.
Yeah, because the histopathology of the skin, to be effective, needs a good dermatopathologist and very good communication. So you need to define very well your problem, your differential diagnostic, and make clear questions to the pathologist.
Yes, even
could that be this or that.
We're not getting slides back. So we're just sending sample and that's it. Okay. And if it's still question, we have no possibility to check it again and again. I have 10 years slides in my clinic, in my practice. So I taking them after 5 years. I'm looking at the slide.
And you can review that and learn.
And and then you learn again and again.
Or change the diagnosis. You know, I think it was not bad, and then I learned that it's another condition. Yeah, that's the good side of biopsies.